It's my proud privilege to be able to share some of my thoughts at Ophthall 2020, which this year has turned out to be a virtual conference due to the current challenges that we have. In this presentation, I would like to share some of my thoughts on electronic medical records and digital engagement, especially in the context of the COVID pandemic, which is challenging us on several fronts. As the saying goes, one should never let a serious crisis go to waste. And this is especially true now when the crisis of this large nature. We also have to come up with innovations and new ways of doing things to not only tide over this crisis, but also for longer term benefit and impact.
So before we go further, I just want to give a small snapshot of Aravind, which started in 1976 with 11 beds in a rented home. And in the last 44 years, we have steadily grown to have 7 large hospitals, which each of them see on a day between 1,000 to 3,000 patients. This, of course, was the pre-COVID numbers. And we have 7 smaller secondary level hospitals, which see up to 400 patients a day. We have 6 clinics, which are run by ophthalmologists in smaller towns. And then we have a growing network of primary eye care centers, what we call as vision centers. We now have 79 of them. On an average day, we see about 13,000 patients, perform more than 1,600 surgeries, carry out a number of outreach camps. On an annual basis, we do more than 3,000 outreach camps. We also have a very significant academic program for residents, ophthalmic technicians, and administrators. And in all of this growth coming from the rented house to this large network, I think would not have been possible without technology. And technology has played a huge role. And I'll be covering in this presentation one slice of it. So in this COVID era, I think certain priorities are emerging. In addition to routine clinical care, I think paramount is ensuring patient safety. That is preventing any workplace contamination. There are protocols in place for doing that. Second, again in the same context, we also have to ensure patient safety and build patient trust. So we need to have not only have safety protocols and awareness, they have to be both visible and I think very diligently followed. But as an outcome of this, I think what we are recognizing, the impact of this is going to be a reduction in capacity, which could be quite significant. And I think the following this protocol strictly, which I think all of us must do, could reduce our capacity by as much as 50%. That is something that we can't afford. So this presentation is essentially about dealing with this challenge through multiple approaches. And I'm essentially going to be sharing our thought process or the different strategic approaches they are taking to this. So the first strategic thought that occurred to us was around managing patient intake or patient inflow. We, like many other hospitals, do not have an appointment system. This is for a well thought through reason. We wanted to have the hospital easily accessible, so we didn't want to have appointment as a barrier come in front. So the entire patient flow is completely walk-in, and in the back end we normally get organized to manage the crowd. And typically, because we don't have an appointment system, bulk of the patients come before lunch. Close to 90% of them come before 12:30 or 1 o'clock. And even within that, we have peaks that varies from hospital to hospital. In Madurai, we would have a peak when we open the hospital at 7:30, and again a second peak at 10 a.m. So the waiting times tended to be long, and the patients had to wait quite a while to be seen. So as a result, in the afternoons, the patient volumes were negligible. So in normal times, what we did was we would use that time for taking classes or doing other things which is not related to patient care, meetings or many other things that need to be done to keep a hospital going. Now with this challenge, we quickly put in a scheduling system. It is not an appointment system. Basically, determining 15-minute slots, and then each 15-minute slot for each clinic would handle a certain number of patients. And we started scheduling patients, of course, with adequate communication to them. And then if patients came in directly, there was a slot available, we'll take them in. If not, we would allot them the earliest available slot and advise them. And this, I think, is feasible now because of the current crisis. So, like I said earlier, we used to have these two peaks. And then as you can see, the arrival post-lunch is tapering down to almost nil. So with scheduling, we are now able to spread out the intake more uniform, so that each hour we are taking in 200, 250 or 300 patients, depending upon the capacity that we predict for each clinic and for each day. So this is one strategy which is already operational across the system. So this scheduling can be done or is done without the need for EMR. But having electronic medical record has opened up a tremendous number of opportunities. So the remaining strategies or solutions are to leverage the electronic medical record. So one is to recognize that in every institution, there will be a bottleneck. It is natural, and then the bottlenecks have to be managed in a very innovative, intelligent manner, because it is the bottleneck that would kind of determine the throughput. So if you have less doctors, then I think the doctors become the bottleneck, and then they determine the throughput. Or if you have less equipment, the critical equipment determines how many patients go through the system. So in this instance, in this crisis, the overall capacity has become the bottleneck. So which means that how do we manage the capacity in an intelligent manner? And one of the cardinal rules of managing a bottleneck is that one should never waste the bottleneck resource or have it lie idle. So the earlier example of scheduling was to make sure that the capacity is never idle, which it was in the pre-COVID days. In the afternoons, it was idle. Similarly, we also recognize that if the bottleneck, which is the capacity, was handling unnecessary visits, then that again reduces the throughput. So we are now in the process of defining an episode. Like episode could be for a pair of glasses, or for cataract surgery, or for glaucoma follow-up visit. Any one of them could be an episode. And then in an organization like ours, and in many hospitals, quite often it would take more than one visit to close an episode. And so then we can question ourselves, is it required? Are these additional visits required? And if not, how do we reduce or eliminate those additional visits. Because for each visit that you eliminate, two things happen. One, the patient is happier because they make fewer visits. And second, in that slot, you can add another patient. No? So this is a second strategy that we are exploring. And today we are trying to see if they can build an algorithm that can delineate an episode from the electronic medical record. So this would be an iterative process. You know? So you look at the number of, so we had, let's say, 1.25 visits per episode. Can that be reduced? And the third aspect that we are looking at is whether we can shift tasks to the patient. Now, this is something that other industries have done very, very well, and many of us recognize that. Now, if you take railways, the railways maybe a decade or more ago shifted the task of the entire ticket booking, payment, all of that to the travelers. And this is something which the travelers enjoy doing. The airlines have done it. Banks have done it. Now, very few of us have really been to a bank, which was the norm earlier days. Now, I haven't been to the bank in the last 10 or 12 years. Everything is done online. I want money, I go to an ATM machine. I want to transfer, I do it online. But we have not done this efficiently within the healthcare system. And the EMR allows us an opportunity for doing it. So I'm just listing some broad areas where this is possible. If you look at activities that need to happen before a patient comes to the hospital, there are activities of registration, which can easily be done outside. History, which is completely given by the patient. We don't have any information on the history. It's all mentioned what the patient recalls and what they tell. This can be done much better digitally. All the insurance details, which we spend a lot of time now, can be acquired so that we minimize that effort when they are in the hospital. And a lot of health education also can be done before they come to the hospital. If they're coming for a pair of glasses, there could be something that they could watch on what it is, what the test will be done, and so it is up to our imagination to see how much we transfer to the patient. Also, once they come into the hospital, also a lot can be done to minimize the effort. Like for instance, in smaller hospitals, it may not be an issue, but in larger places, navigation becomes an issue, which could be done quite easily by building an app that interacts with the electronic medical record to tell the patient where to go next and where it is located and so on. And the patient can be kept informed, because all of us will recognize the effort and the frustration all of our staff have to face, because the patients are constantly asking about where to go, what the next, how long it will take, and many of those questions. And I think all of this can be very effectively done digitally based on the EMR. And then about each investigation, before they undergo the investigation, they can be briefed either through text or through digitally or through visuals. And of course, with the advent of UPI, Google Pay, Paytm, and many other venues, digital payment is also possible. So you can kind of get a idea of how much we can transfer to the patient in this era. Another area that we are looking at is, again, from a capacity perspective, because the longer a patient spends in the hospital, they take up that much capacity of the hospital. The shorter they spend, I think that much capacity is released for taking in more patients. So we are diligently looking into how do we reduce patient care cycle time. So it starts with how do we monitor the cycle time and set targets, which is now possible, which can be automatically done from an EMR. In a manual system, this has become a very tedious task. And then we can even monitor the cycle times granularly for each of the sub-services within the hospital, registration cycle or refraction or lab or or investigations, whatever. And wherever we feel that the time taken is longer than the benchmark or the target that is set, one can do a root cause analysis. Is it due to capacity? Is it due to staff motivation or staff not available? And then appropriate remedial measures can be done. We can rationalize investigations or cross-consultation. Even if cross-consultation is required, I think with EMR we can do e-consultations rather than physically sending the patient to another doctor or a specialist. And then as we pick through this, we can make whatever remedial stuff needs to be done by investing in additional staff or equipment so that the resources are balanced. And again, EMR makes this really feasible to approach. And finally, can we leverage technology to provide remote care? And this is going to become more and more of a necessity and a reality, because the common public is now getting very much comfortable with a lot of remote services. Today, I don't think there's any household wherein the child is not learning remotely. If they have a child, they have lots of online classes which they do with their parents' smartphone or a tab or whatever their economy allows them to do. So receiving services remotely is not a foreign idea anymore. And then patients also will start questioning as to why should I come just for this simple thing? Can't I tell what the problem is and then get your advice remotely? I think the demand for remote care will also happen. So we really need to figure out a process which we are very actively working on to integrate remote care with real-time care. Now, our EMR looks like what the screen is now. And what we're hoping to do is to show against each name certain icons. Now, for example, if it says a video icon is shown, means clicking on that should immediately bring up the patient on the screen visually to talk and interact with them. And then you have whatever information is available. If they're an old patient, you have the past visit data and then the details about the current history, which could have been worked up by a junior doctor or a technician or someone within the system, which workflow you will have to determine. Or if it is a new patient, then you have lesser information. But in a teleconsultation, we work with what information we're able to access remotely. Now with every smartphone having a camera, quite often patients can take images and one can guide them to take good images. I think Shankar has made good progress in doing that. In tutoring, they have a video tutoring the patient as to how to take good photograph of their eye from the smartphone. So if it is a patient doesn't have video capability like Zoom or whatever, they could be connected through their phone, and then in which case their phone icon would show. Clicking on it should automatically dial and connect the patient. So all of this is possible today. I'm not talking about what is not possible. In fact, they've been possible for quite some time. But then we didn't have the need to harness it. And today, both the need is definitely there, and then it's only a question of time before the demand also kicks in. And then to the extent that we get organized before that, we'll be a bit ahead of the game. And I want to share with you data from one of the hospitals in California. It is called Kaiser Permanente, and they're the major providers of healthcare in that for that state. You know, they're quite large. They have more than 10,000 doctors working in the network. And then if you look at their numbers, it's absolutely mind-boggling. You know, last year they had 148 million patient engagements. They're not physical visits, but they're patient engagement, of which less than 40% were physical office visits, physical hospital visits. The remaining 62% were all digital engagements, which could be just getting a medical report to getting an advice or whatever. So many institutions in the West, especially progressive ones like Kaiser, are already ahead of the game. And so in some sense, we need to catch up. And I think the current crisis is both giving us an opportunity and a wake-up call to do that. So the impact of all of this, we anticipate, once we put all of these things in place, which are actively being pursued within Aravind, some are already in practice. We feel that with what we have, we can actually increase our capacity by 20 to 30%. That is, our intake of newer patients would be significantly higher with the same staff, with the same infrastructure and equipment. And we'll be doing this without any compromise on quality of care, as I had demonstrated and you can visualize. And all of this is going to reduce effort, visits, and cost to the patient, and significantly enhance revenues to the hospital. So this is going to be a win-win. So the take-home message really is that crisis like COVID is really not going to change the eye care scenario in terms of impacting its incidence or prevalence of various eye conditions. I think cataracts or refractive errors or glaucoma or whatever it is going to occur, happen, exist as before. And and again, whatever challenges that we are facing now is universal. It is not specific to eye care or to a particular practice. So there is no benefit in feeling victimized or complaining about it. I think we really don't have any other option other than to innovate. And I want to conclude by saying that the digital platform that's very rapidly evolving is giving us lots of opportunities to kind of do things, to do new things, innovate, and stay relevant. Thank you very much.